Hello everyone, very good evening. Welcome back to our pediatric channel. Today we will talk about HIE part 2, that is Hypoxic Ischemic Encephalopathy part 2. So in this video we will cover about our pathology behind your HIE and the treatment part. So this finishes our Hypoxic Ischemic Encephalopathy. Okay. So going on to its pathology, it is mainly the selective neuronal necrosis. So first is your selective neuronal, that is it affects mainly the neurons that is being deprived of the blood supply, that is called as selective neuronal necrosis. So you have pathology behind the term and the preterm children are different. So that was so I have made us two separate headings. So the pathology behind you have term child and you have preterm child. So the pathology behind term child is mainly the area that is being affected is your watershed zone. So what is the watershed zone that is being affected is the area that is being supplied between your anterior cerebral artery and middle cerebral artery. So the area that is being supplied between your anterior cerebral artery and middle cerebral artery, that is the main area that is being affected in your term child. That is called as your parasagittal area. Next, while coming to the preterm child, in preterm child mainly it is a periventricular leukomalacia. So what is the meaning of leukomalacia? Leukomalacia meaning it is a focal and diffuse white matter injury. That is when you take an MRI or when you take an MRI, you will be seeing a small cyst-like cavities or small cavities-like lesion that is being present on both the sides of your ventricle. Okay, so that is called as leukomalacia. That is mainly it is because of your white matter injury. There will be a leukomalatic changes or cavities in the brain in the preterm child. Okay, next, particular areas of the brain can also be affected. That is mainly your deep nuclei of the brain. So deep nuclei of the brain will not get the adequate blood supply, mainly your basal ganglia and hippocampus and your Purkinje cells of cerebellum. So that the child can result in your CP, called as dyskinetic CP. Okay, so based upon why this pathology is important here is because based on the pathology you have different phenotypic or you have different clinical presentation in the child. With that you can identify your pathology behind the hypoxic ischemic encephalopathy also. Okay, this is dyskinetic. The child can result in dyskinetic CP if the child has a deep nuclei of the brain are getting affected. Another one more point I have to tell you in leukomalacia is that is a focal and diffuse white matter injury, that is mainly your oligodendrocytes, your neurons, your interneurons, all the three will be damaged in this child. Fine. So pathology are four main pathology. One is selective neuronal necrosis. Second one in term child is your parasagittal area being affected. Third in preterm child is your periventricular leukomalacia. Fourth, there can be a deep nuclei of the brains that can be affected. Fine. In term child, so what will be the neurological outcome in a term child, or what can be the type of CP in a child with this hypoxic ischemic encephalopathy based upon its pathology. So that one we will see here. So the term child, mainly the term child will present with spastic quadriplegia. Spastic quadriplegia meaning, so I will write it here, the term child will be presenting with spastic quadriplegia. So what is quadriplegia? It is all your four limbs will be affected. First, mainly the child will get affected, this upper limb will be affected more than the lower limb. On duration, on the sequence goes on, the child's both upper limb and the lower limb will be equally affected. So in a term child, the child will present with the spastic quadriplegia. When you take a MRI picture or when you do the pathology behind this spastic quadriplegia, you will be finding a multicystic encephalopathy cerebral malformation. Fine, this is in term child. Next, in preterm child, mostly the preterm child will be presenting with spastic diplegia. So what is the meaning of spastic diplegia? It is your lower limb will be more affected than your upper limb. This one the parents will identify when the child begins to crawl. That is, the child will not be able to crawl. The child will drag the lower limbs together while the child is moving. That is spastic diplegia. That is also called as commando crawl. Okay, so this is the meaning of spastic diplegia. Spastic diplegia mainly it will be present in your preterm child. The pathology behind this will be your periventricular leukomalacia. Fine. Next is your spastic hemiplegia. Spastic hemiplegia meaning one side of your body will be affected. It is either right upper limb and lower limb or left upper limb and lower limb can be affected. It is because of your selective cerebral injury. That is because of your selective infarction or necrosis. The spastic hemiplegia can occur. Next, when this basal ganglia gets affected, the child can result in dyskinetic CP. When your cerebral, that is when the Purkinje cells of your cerebellum getting affected, the child can result in ataxic CP. Okay, so these are the main pathology and the CP type behind your hypoxic ischemic encephalopathy. Next, what is the investigation here? So you will be doing a neuroimaging. So the neuroimaging for screening and also you have for your definitive diagnosis. For screening, it is mainly your USG cranium, and for definitive diagnosis, it is your MRI brain. Supposing if you wanted to find the lesion, whether the lesion has occurred earlier or not. So to find the lesion at the at most earlier stage, that is before like in 3 days or 5 days, you have to do a diffusion weighted imaging or diffusion weighted MRI should be done to find the lesion at your earlier stage. While this MRI brain can pick up the lesion only after 1 week of life. Okay, next you have your for what you do this USG cranium. USG cranium is mainly done when you suspect a bleed. When you suspect a bleed in a child, you have to do a USG cranium, and USG cranium can also pick up your leukomalatic changes. So USG cranium can pick up your leukomalatic changes and also your bleed. Okay, next you have is amplitude amplitude adjusted EEG you have. That is only a bedside monitoring of seizure activity, and the main definitor is your conventional EEG. Next, the treatment of choice. First is mainly your supportive treatment, everything you will give. But for a child with moderate to severe hypoxic ischemic encephalopathy, the treatment of choice will be your therapeutic hypothermia. So in therapeutic hypothermia, what is the temperature you have to maintain in therapeutic hypothermia? It is mainly between 33 to 34 degree Celsius is the temperature that is being maintained in therapeutic hypothermia. So it's the gold standard treatment for child with moderate to severe perinatal asphyxia or your hypoxic ischemic encephalopathy. In which child this therapeutic hypothermia should be instituted. So you have a criteria, a separate set of criteria for the child to give your therapeutic hypothermia. That is when the gestational age of the child is 35 week or more than or equal to 35 week you have to give, or when the birth weight of the child should be more than or equal to 2 kg. Fine. When second criteria, when it should be initiated, it should be started within 6 hours of the birth. Third, the child should have some evidence of asphyxia. So evidence of asphyxia meaning when the Apgar score is less than 5 at more than or equal to 5 minutes, or when the child is needing positive pressure ventilation after 5 minutes of birth, or when the child is having cord blood pH of less than 7. So these are some of the evidence to tell that the child is having asphyxia. That is when the child is having an Apgar score of less than or equal to 5 at 5 minutes, or when the child is having a cord blood pH less than 7. Third, or when the child is needing this positive pressure ventilation till 5 minutes of birth. These are the evidence to tell that the child is having asphyxia. Next, evidence of encephalopathy. Evidence of encephalopathy meaning the child is having any one of the following. That is when the child is having clinical seizures, or when the child is having an altered state of consciousness. That is, the child is in coma, lethargy or stupor. And any one of the following meaning, and the child is having any hypotonia or abnormal oculomotor or pupillary reflex, or the child is having abnormal or weak suck. These are the evidence to tell that the child is having encephalopathy. So the criteria for a child to be given this therapeutic hypothermia is when the child's gestational age should be more than or equal to 35 weeks, birth weight should be more than or equal to 2 kg, started within 6 hours. Why this 6 hours? Definitely why? Because in previous video I have talked about the pathogenesis. The time time gap between your primary injury and your secondary injury, the time gap is your 6 hours. So to prevent this secondary injury, you have to start your therapeutic hypothermia treatment within the 6 hours of birth. And whether the child is having evidence of hypothermia, asphyxia, or the child is having evidence of encephalopathy, you have to start on your therapeutic hypothermic treatment. What is the mechanism behind your therapeutic hypothermia? You have main mechanism is this. There is a decrease in the cerebral metabolism. So there is decrease in cerebral metabolism and also your blood flow to the brain. So it will cause a decrease in cerebral metabolism and blood flow to the brain. So that meaning there will be a decrease in the edema. Second, this can also decrease your glutamate. Glutamate is your excitatory neurotransmitter. So it will decrease your glutamate and your nitric oxide, thereby leading to less oxidative injury. Next, third, it will decrease or it will inhibit the free radical injury. This free radical injury is mainly responsible for your secondary injury to your penumbra. So it will inhibit your free radical damage and your lipid peroxidation, thereby reducing your apoptosis and your necrosis. So this is the mechanism behind your therapeutic hypothermia. So what are this ADR is nothing but your adverse effect or adverse reaction to your therapeutic hypothermia or thrombocytopenia and bradycardia. So you have to monitor for these two. Next, what are the contraindications for which child you will not give this therapeutic hypothermia? So when the child is having a major congenital malformation, so when the child is having a major congenital malformation, or when the child is having any suspected or known chromosomal disorder. Third, when the child is having an active bleed. Fourth, when the child is having a catecholamine resistant shock. So these are the conditions. These are contraindicated for your therapeutic hypothermia. So this is the about your pathology and the treatment part regarding your hypoxic ischemic encephalopathy, that is mainly needed for your university exam and also for your NEET PG entrance. Thank you.